So it's 3, 2, 1. We are live to the audience. You can start your session. Over to you, ma'am.
Okay. Hello, everyone. I am Dr. Manasa. I work as a consultant urologist at Ramaya Medical College and Memorial Hospital, Bangalore. So today we are going to talk about, discuss about a very important topic, that is overactive bladder. This is particularly common in both men and women above the age of 35 years, with the initial incidence being more in women, but as the age advances, you see more of this incidence in men because of prostate and other problems. So to give you a basic idea about how the bladder works, normally what happens when the urine fills, the bladder has to relax. So it relaxes till the bladder is filled up to 350 to 450 ml, which is the normal capacity, following which it sends signals to the brain. So then brain, that is the pontine center, it activates certain reflexes and sends some signals back into the bladder. So this is when the bladder starts to contract, and then the sphincter, this is the sphincter relaxes and the person tends to void. So what happens in an overactive bladder is that there is a miscommunication between these signals. So what happens, instead of sending the signal following a capacity of 350 to 450 ml, the bladder is sending signals quite early on. This could be because of a neurogenic cause or a myogenic cause, or could be an underlying infection, which I'll be coming in the next few slides. So as a result of which there is misfiring occurring. So the person tends to feel the sensation even at 50 ml or even at 30 ml filling of the bladder. So naturally they have the urge to pass urine and they're unable to hold this because there is an involuntary contraction occurring. Normally what happens at 350 to 450, there's a signal sent to the brain. And what happens in a normal person, you're able to hold it for a while, but this is not possible in a patient with overactive bladder. Now, overactive bladder as such is a very huge topic. It has undergone revolution in terms of definition over the last few years. There are various aspects which have been removed and various which have been added, which I'll be discussing in the next few slides. There are various guidelines regarding how to manage the condition, not to overtreat and not to even undertreat, as well as the changes have occurred in terms of therapy. That is, earlier it was only restricted to medication, but now you have newer mechanisms of treatment, like installation of Botox into the bladder, which gives a temporary relief, as well as and there is something known as the sacral neuromodulation, which is in fact a permanent solution. So to define overactive bladder, it is not a disease per se, it is just a constellation of symptoms. So it should include 4 symptoms predominantly. That is the urinary urgency, which is usually accompanied by frequency and nocturia, with or without the presence of urge incontinence. Urge incontinence in simple terms means the urgency followed by leak. So this should be in the absence of any underlying pathology, whether it could be an infection, a cancer, or a neurogenic origin, overactivity, or it could be because of malignancy. All these things need to be ruled out to make a diagnosis of overactive bladder. So when you look at the incidence, why is it so important is because this is one of the studies conducted in 2014, where they did a pan-Asian study, and they did find that 50% of the Asian women have symptoms. Either they are delay in seeking treatment or they hide it. The reasons, which I will be coming in the next slide. So the burden itself is very high. And if you look at Indian statistics, there has been one study that has been conducted, which has shown that about 1 in 6 women above the age of 40 years do present with this problem. And surprisingly, if you see at the slide, that is the last part of the bar diagram, you see that only 20% of these patients actually come to us and seek treatment. So why is this barriers to treatment? Why is this discrepancy that is occurring? That is mainly because a lot of people consider this as a part of normal aging or even normal part of everyday life. They think it's quite normal to go frequently. They think it's normal to wake up. A lot of people don't even feel disturbed by waking up to pee. This is what I have come across, and this is what has been proven in studies as well. So, and some of them don't think it's so important that it needs treatment. A lot of people find it too embarrassing to discuss. And a lot of people do believe that no treatment is going to help this condition, which is falls. So before going ahead, what about, like I mentioned earlier, what about the incidence of overactive bladder? So you see that around 18 to 20 years, it's only around 5%. But as the age advances, it reaches almost up to 20 to 25% overall, all over the world. Now, you also see that in the early age, it's the women who have predominantly predominant symptoms of overactive bladder. But as the age advances, it almost becomes equal at 70 to 79 years. So coming to clinical manifestations, that is how the overactive bladder presents. Like I said before, there are 4 important symptoms: frequency, urgency, nocturia, and urge incontinence. Now, let me describe all of this one by one. See, the urgency is nothing but the frequent, strong, sudden, unpredictable desire to urinate. That is, you need to go, you have to go to pee. Otherwise, you feel that the urine is going to leak. Now, this is seen in about 50% of the patients. And this is a must for a diagnosis of overactive bladder. Now, most of the patients with overactive bladder have what is called as frequency. So when do we call that the patient has frequency? Is when the number of times the person passes urine increases to more than 8 times over a 24-hour period. More than 24-hour period, we can say 8 times during the day. Another important thing, like I mentioned earlier, is the presence of urge incontinence. That is the involuntary urine loss, which is associated with sudden, strong desire to void. So the patient feels the urgency, but by the time the person is about to reach the toilet, the urine leaks into the clothes. Now, this is seen in about 1/3 of the patients. And when we have such patients, we call it wet overactive bladder. And if they don't leak, we call it as a dry overactive bladder. Now, dry, it tends to occur most, that is without incontinence, tends to occur most common in men, whereas with incontinence tends to occur most commonly in women. Another important thing, most of the patients do come to us is because of nocturia. That is, their sleep is disturbed. So this is one of the most common presentation. So if there is a need to wake 1 or more times per night, we term it as nocturia. Now, this has to be differentiated from what we call as polyuria. That is, the amount of urine produced itself is more, is called polyuria. Now, this is because of various other conditions, like probably an asthma or a COPD, that is a chronic obstructive pulmonary disease, what we call. It could be seen in diabetes, or it could be because of a heart failure. So we need to rule that out. We need to make a proper diagnosis of nocturia. And there are certain medications also which we need to take into consideration before defining nocturia. So like I said, it's just a constellation of symptoms where they have urgency, frequency, 1/3 have urge incontinence. And another important thing is some of them do have very less voided volume. That is about 50 to 100 cc, while certain people do have about 300 to 350 cc. Now, how do you differentiate this is that if it's about 50 to 100 cc, we call it reduced capacity. Now, these are the patients who need aggressive treatment as compared to those who have a voiding only at 350 to 450 cc, in whom probably it's the excessive secretion of urine is what is causing the overactivity. Because the volumes of urine output are high, that is the reason they are going, not because of misfiring. So what we have to look at is the causes of urinary incontinence. Now, as I said, overactive bladder is just a manifestation. So where it can include incontinence. So before making a diagnosis, we have to rule out other causes. So there are certain transient causes. Most importantly, and most commonly what we see is in a patient with frequency and urgency is they have urinary tract infection. Now, they may have other symptoms, like they can have bladder pain, they can have fever, they can have a prior history of UTI. All these need to be taken into consideration. In these patients, what does happen is that once you treat the UTI, the overactive bladder eventually settles. I mean, the overactivity usually settles. So, but usually what happens is in an infection, if you give an antibiotic for about a week, the symptoms do start subsiding. Although the infection is cleared, there is some amount of inflammation, that is residual inflammation present in the bladder. So as a result of which they can continue to have overactivity, that is frequency and urgency, despite clearing of infection. So with that, those are the ones whom we need to supplement with certain medications. Now, the other causes that need to be ruled out is the neurological causes. Then what we term as bladder outlet obstruction, that is voiding dysfunction. Basically, patient is unable to void properly, as a result of which they can be having what is called as increased residual urine. Now, this is what is triggering the signals to the brain, as a result of which patient feels like going to the loo more frequently. Another important thing is the underactive bladder. Again, the bladder is not able to pump out urine itself. So again, there is residuals and the similar pattern ensues. So all these conditions do need to be ruled out before making a diagnosis of overactive bladder. Now, again, when the patient comes to you with incontinence, what we need to differentiate is whether the patient is having only urge incontinence, or whether there could be other forms of incontinence that one can present as well. So if you have incontinence which is associated with cough, or which is associated with straining while working out, or while just simply walking, or laughing, sneezing, we term it as stress incontinence. And when the bladder is overfilled and the patient, particularly in obstruction, what happens is that patient is unable to void. So there is a lot of residual urine, like I mentioned earlier. So it starts dribbling little by little. So that is what we term as overflow incontinence. And if there is an underlying neurogenic cause, we call it neurogenic incontinence. Now that can manifest as stress, urge, or overflow. So it's very important when a person comes to us, we need to rule out whether it's stress, urge, or overflow. Now, there are certain factors which give us a clue regarding whether it is an overactive bladder or stress. Like I said, the symptoms, that is urgency, which is not seen in stress. Frequency, again, not seen in stress. Stress, mainly leakage is associated with only physical activity. And the amount of urine that leaks in stress is very little. Only very rare cases where they have total incontinence, they might present with large volumes of leak. Then again, ability to reach the toilet in time following an urge to void is possible in stress, but it is not possible in urge. And in stress incontinence, they usually don't wake up at night. And other thing, what we look at while treating is whether the patient has got what is called as mixed incontinence. Now, mixed incontinence is when they have both urge as well as stress. Now, this is usually seen following delivery in a woman, where they usually come to us with both urge as well as stress. So what we do in such cases, first we treat the predominant symptom. We make them chart out the symptoms by what we call as a bladder diary. I'll show the slide in the, I'll show the diary in the subsequent slides. So we map out the incontinence. We try to find out which is the most predominant symptom, and we treat accordingly. Now, if stress is bothering them much, it is better to treat the stress first, followed by the urge. But in case if the urge is bothersome, we tend to treat the urge first, while we give advice pelvic floor muscle exercises, which works both for urge as well as stress incontinence. Now, a lot of talk, whatever I've said, why is it so important? Now, that is because overactive bladder significantly impacts the quality of life. It does cause depression. There is loss of self-esteem. Like domestically, there's a lot of money spent on it because they require special clothing, special bedding, and occupation is also affected because this mostly leads to absence from work, mainly because they're embarrassed, and there is also decreased productivity, mainly because they're half the time going to the loo, and they're unable to participate in longer discussions or meetings. Now, they also have they feel limited to travel. They limit their travels, they limit their outdoor activities, they limit their social interactions because they need to map out where is the loo before traveling. So as a result, most of the women come to me telling that they're not able to visit temples, they're not able to visit their relatives because the journey itself is cumbersome. They don't find the toilets, and they're scared that once they use a public toilet, they tend to develop UTI. So that is again true. And as a result, it's very essential that we need to treat the patient holistically. Another important factor that occurs with overactive bladder is the avoidance of sexual contact and intimacy. Now, this usually happens because there's a lot of spillage, there's a lot of soiling occurring, as a result of which there's a lot of there's a decreased interpersonal relationship, as a result of which there is ostracization, and as a result of which there is, people do I have seen a lot of patients who come to me and say that they have started living in separate rooms, they use a separate loo, and they've not had an intercourse over the last 3 to 4 years, and as a result of which there is a lot of partner dissatisfaction. So this is the overall burden of overactive bladder, and as a result it needs to be treated and addressed properly. So when a patient comes to us with overactive bladder, how do we diagnose it? First, we ask a thorough history just to identify the type of incontinence, as well as to rule out the causes, followed by which we do a physical examination where we assess the general condition. Just by looking at the gait, we can assess. There are certain conditions like Parkinson's, which have a characteristic gait. So when the patient is walking to our OPD itself, we come to know whether this overactivity is because of neurogenic origin. Then in examination, in a male, we characteristically examine for prostates, we examine for any strictures. Then we look for palpable bladder. It could be that the patient is simply in retention and manifesting as incontinence. So we do a thorough neurological examination as well. Now, in the females, we also do a pervaginal examination. We look for any prolapse, which could be a cause of this. Anything obstructing the urethra, there could be a lesion, or we could be associated vulval infection or vaginal infections, which could be a trigger for the overactive bladder. Another important thing in the history, what we ask and what is very important for you guys to know is that constipation triggers overactive bladder. Now, there is a very fine balance because the nerve supply to the lower part of the bowel as well as the bladder is same. So if you have constipation, there is a high chance that you have overactive bladder. In most of the patients, when we treat this constipation, the overactive bladder usually settles. So this is what we term as bowel bladder dysfunction. So this needs to be looked at. So once the patient comes to us, the first thing we do after examination is send for a urine routine and a urine culture to rule out infections. It can also tell us about the blood in the urine. It can give us regarding any fungal infections present in the urine, if there is any proteinuria, glucose in the urine, which is suggestive of diabetes. Then we send for cultures to identify the organism and to treat accordingly. At the same time, we do an ultrasound to look for the condition of the kidneys, if the thickness of the bladder wall, how much of urine is remaining in the bladder once the patient voids. Or we also look for if it's a stone, which is a trigger. Stone also can cause, particularly if it's a stone stuck in the lower part of the ureter, which is very close to the bladder, or if there is a stone in the bladder itself. Other important conditions like carcinoma in situ, that is nothing but the very superficial layer of the bladder has cancer. So that can also present as overactivity. So we also need to rule that out. In certain cases, we might even send what is called as urine cytology. That is, the cells in the urine are sent separately to look for cancer. So that also may be required in a patient who already has a history of cancer, or if there is a family history of cancer. Another thing, like I said earlier, is we map out the type of incontinence. So this is the chart we provide to the patients, wherein we ask them to record the intake, the urine output, they measure it, at what time they consume liquids, how much liquids they consume, at what time they pass urine, and how much urine they pass, and are there any episodes of leak. So by this, we get a clear picture of how frequently the patient is voiding, when are there any triggers, are there any foods which are triggering that. If there is a patient who's coming to us following afternoon lunch, so we try to understand whether there's anything like, there are patients who consume a lot of barley water in the afternoon. So that could be a trigger, as a result of which between 3 and 5, they tend to go and void more frequently. See, this is one such patient where he has just voided only 50 to 75 ml. Otherwise, his capacity looks normal. So we usually ask them to map this out for a minimum of 3 days up to a maximum of 7 days. So 1 day is not sufficient, because what patients tend to do is that the same day they try to restrict the amount of fluid intake, and as a result, we don't get a clear picture. So rather, we have a longer registration of symptoms, that is longer duration of registration of symptoms, that is about 3 to 7 days. And that gives us a clear idea as to when to give the medications, where to restrict the fluids, and where to advise exercises, when to perform the exercises, as well as what foods to avoid. So there are certain other tests we use, such as urodynamic study, where we assess the bladder pressures. So bladder pressures are usually assessed to, particularly if we are suspecting a patient where with an underactive bladder, probably because of a diabetes or a neurogenic cause, where the patient is not able to pump out urine well. Second reason why we do urodynamic study is, like I said, mixed incontinence. So we have to rule out stress from urge. So we want to know whether is it stress that is inducing the urge, or whether these two are separate entities. Now that can be made out with a urodynamic study. This is usually done on OPD basis with a certain amount of preparation. Another thing is cystoscopy, particularly when you're suspecting a malignancy, or it could be an underlying tuberculosis if there is a family history, or there was a personal history of a chest TB. Ultrasound, although guidelines do say that they do not recommend ultrasound, we usually do in our routine practice. Cytology, although not recommended, when the patient has blood in the urine and we suspect malignancy, we do it. So when a patient usually comes to me with an overactive bladder, they usually have already self-managed the symptoms. That is, they would have tried to void frequently to avoid the urgency episodes. They would have reduced the fluid intake on their own. They would have reduced sugar intake. They would have started wearing pads. So nearly about 2/3 of the patients have symptoms for almost 2 to 3 years before they seek treatment. And one more important thing to note is that a lot of patients usually tend to go to a general physician for this, or ladies tend to go to a gynecologist for this, as a result of which they are not being evaluated for other causes at all. And probably if you treat the underlying cause, the overactive bladder, the overactivity would immediately settle. So it's very essential that such patients need to be evaluated clinically. Thorough history needs to be taken, examination to be done. Ultrasound also needs to be done, followed with a urine test. So what are the goals of treatment? So when a patient comes to us, first thing what we try to do is decrease the episodes of urgency and frequency, eliminate the urge incontinence completely, while we also ensure that patient is compliant with the medications that is being advised, because a lot of medications have a lot of side effects, particularly the antimuscarinics, which I'm coming in the next slide. Another important thing, it's very essential while we treat, is to meet the expectations of the patient, which is very, very essential, because there are so many patients who are quite happy voiding frequently during their day, but they want their symptoms to be relieved only at night. So that is what needs to be achieved. So the basic first line therapy, what we give is behavioral modification. That is, educate the patient regarding the overactive bladder, tell them that it's not a very serious condition, provided all the underlying conditions are ruled out. Then we advise timed voiding, delayed voiding, diet and fluid intake restriction, and pelvic floor exercises. So what is bladder training? Like I said, most of the patients do come to us with having tried this. That is, supposingly if the patient has consumed something at 9 and the patient has incontinence at around 11 o'clock. So what we do tell them is around 10:45, voluntarily go and pee. So this helps in emptying of the bladder, as a result of which the urge incontinence is reduced. So, or we fix a particular time, like every 2 hours you go and pass urine, or every 3 hours you go and pass urine. So this leads to what is called as retraining of the bladder. So the misfiring stops. And this helps in relief of symptoms. Another important component is the pelvic floor training, which helps both in stress as well as urge, and both in males as well as in females. So we ask them to contract the pelvic floor muscles and hold it for some shorter duration, that is 2 to 5 seconds for a while. Then again for longer durations, that is 8 to 10 seconds for a while. So a common set of regimen is 10 contractions, 5 to 6 sessions per day. So although this is what is said, in clinical practice, what we advise is do 100 such contractions every alternate day. If you can go and look at any YouTube video, you will find how to perform Kegel's exercises more effectively. You can go to the Ramaya website itself. But one thing to note is that with pelvic floor training, the symptoms improve only in 30%, and they might need a medication subsequently. And it takes about 6 to 12 weeks for it to start its action. Another important thing is fluid and dietary modification. So avoid foods or beverages which tend to irritate the bladder. There are a lot of irritants. Basically, anything which contains caffeine is an irritant. Avoid coffee, avoid tea. Chocolates are again irritants. Spices, spicy foods, because they cause acidic urine. They tend to irritate the bladder mucosa. Tomato-based foods. Try to avoid these foods. Alcohol again is an irritant, so tends to be causing, as it is, it causes diuresis. Second thing is it irritates the bladder mucosa. So you need to use it with caution and drink. Another important thing is empty the bladder before you sleep. This is particularly in patients who present with nocturia, that is nighttime voiding. So always consume liquids 3 to 4 hours before you go to sleep, and always pee before going to sleep. And whenever you're consuming fluids during the day, take only small amounts during the frequently, rather than having one large glass or 1 liter of water at one point of time. Then you tend to void more frequently. So this was about behavioral modification, which is the first line. Now the second line treatment is where we offer medications. So there are various medications available. They are grouped into antimuscarinics and beta-3 adrenergic agonists. Earlier, we used to use antimuscarinics more commonly. We have various drugs, that is solifenacin, darifenacin, tolterodine, which we most commonly use. Oxybutynin we prefer to use only in children. And of late, we have been using more of mirabegron. Now, why? Because anticholinergics, although they are efficacious, they have a lot of side effects. That is, they cause dry mouth, they cause constipation, and particularly in the elderly, since the incidence is more common in the elderly already have some amount of cognitive dysfunction. So supposingly we are giving this drug, there are certain CNS side effects with these medications. So they can present with restlessness, irritability, the disorientation. So we need to find a delicate balance between its effectiveness as well as its adverse effects. And there are and another important thing is these drugs, they are not very selective to the bladder. There are receptors for these drugs elsewhere in the body. So in the eyes, they tend to cause dry eyes, there is blurring of vision, there's constipation and dry mouth, like I mentioned. So what happens is these patients tend to discontinue medications within 2 to 3 months. They're very unhappy to take these medications. So because of this, the newer drug, what we most commonly use is mirabegron. Now with mirabegron, the advantage is that there is less chance of retention. Normally what happens, any drug what we give for overactive bladder is to relax the bladder during its storage phase. So as a result of which the pumping capacity of the bladder itself can decrease. So what we do in such cases, particularly in those with overactive bladder, we assess the post-void residuals, like I said. So if it is more than 150 ml, we have to use antimuscarinics, the earlier medications, with caution, because the patient can go in for retention. But with mirabegron, the advantage is that although it relaxes the bladder, it does not affect the pumping capacity of the bladder. So that is one advantage. Second thing is it is very selective to the bladder, so it does not cause other side effects. The only side effect with it is it increases the BP, particularly in those who have already what is called as malignant hypertension. So malignant hypertension is when the BP is not controlled even with 3 or more medications. So in such cases, or in a patient with stroke, we don't give mirabegron because it tends to increase the BP. Another important thing here is in severely allergic patients, we don't tend to give mirabegron. So we now normally use this as a first-line drug along with behavioral therapy, or we use it as a combination therapy along with an antimuscarinic. So ideally what we do is we start off with solifenacin, that is an antimuscarinic. And if it's not working, we start with a 5 mg, a very low dose. We increase it up to 20 mg. Normally patients are happy with about 10 to 15 mg. Even in case they aren't, or if they have side effects, then we reduce it back to 5 and we add a mirabegron of about 25 to 50 mg. And supposingly if this also doesn't work, then in males who have got poor flow, we can add tadalafil, or we also, in those with prostates, we also add alpha blockers. That is to improve the flow of urine. So this is how we medically treat overactive bladder. So supposingly this is failing. We have already given solifenacin, we have given conservative we have given all the behavioral modifications. We have advised pelvic floor muscle therapy, and we have advised mirabegron. So what do we do after, if the patient is not responding to all of this? Then we tend to advise, we term it as refractory overactive bladder, that is not responding to any medications. So there are various causes why this occurs, mostly neurological causes, mostly because of excessive sensitization of the nerves. So in such cases, what we do is we advise Botox to the bladder. That is, we inject Botox, about 200 units of Botox. We dilute it in up to 10 ml and inject 1 ml or 0.5 ml in about 20 to 30 sites. So this tends to relax the bladder, but one problem with this is it can make the patient go into retention. So initially patient may have to self-catheterize and empty the bladder for about 2 to 3 weeks till the bladder contractility recovers. Another thing is it is contraindicated in the presence of an infection, or if there is a hematological bleeding abnormality in a patient, or if the patient is pregnant, we don't tend to advise Botox. Another thing here to note is that Botox, the effect lasts only for, it starts at 2 weeks and it lasts only for up to 6 months. So patients may need repeat injections over time. And that is one thing which is very important to note. Another newer thing that has come into the market is the sacral neuromodulation. Sorry for the spelling mistake, it's sacral. So here what we do is we place an electrode near the spine where the nerves are coming, nerves to the bladder are coming out. So there is a controlled stimulation of these nerves we do by placing a sacral electrode. So what happens here is that first what we do is we put a temporary stimulator that is for up to 1 year. So we see how the patients improve. That is, if there's a 50% improvement, then we ask them to go for a permanent modulator. So the advantage is that it is permanent, but the one thing what we need to look at is the cost, because it is the cost of the machine and the implantation itself varies between 5 to 7 lakhs. Supposingly the patient is having a small capacity bladder, that is, the bladder has shrunken in size for some reason, that is, the patient that has a past history of tuberculosis, or patient has undergone tumor removal, a partial removal of the bladder has been done. So in that case, what we can do is advise what is known as a cystoplasty. That is, we cut open the bladder and put a part of the bowel on top of the bladder, refashion it as a part of the bladder. So we increase the size, we increase the capacity, and that's how we decrease the urgency and frequency. However, it has its own side effects because the bowel secretions differ from the bladder mucosal secretions. As a result, they could have clogging of urine, there could be recurrent infections. So all these need to be kept in mind. So that was about the overactive bladder in a nutshell, where I discussed about the symptoms, the how to investigate, how they present with, why they present late, and why they present in such lesser numbers, and the treatment modalities that are available. So to conclude, I would like to say that the cause of the overactive bladder is not completely understood. So treatment is always in a stepwise fashion: conservative, medical, followed by surgical. Then treatment of OAB can be rewarding. So it needs to be tailored as per the patient's need. And although complex condition, there are various promising treatments available. So it's very essential that we diagnose the condition early. So it's very essential that you present early, because after a certain time, what happens is that the bladder is trained that way. It is trained to void frequently. So to retrain itself takes a very long time. So it's very essential that you come out with your symptoms very early, so that we can treat them early on, so that the long-term complications of the surgical requirement is not needed. Thank you. So.
Thank you, ma'am. Thank you so much for your wonderful presentation. Ma'am, there are some questions in the chat box.
Yeah, I can see that. One is, what is the symptomatic difference between underactive bladder? See, in underactive bladder, like I said, the bladder is not able to pump out urine. So they usually present with poor urinary flow. That is, they need to strain a lot to void. They need to sit in the loo for a very long time to empty their bladder. Sometimes sometimes they have to apply pressure on the lower abdominal part, that is to what we call as the Creed maneuver, to empty the bladder. Now, this occurs particularly following a neurogenic cause, or it could be because of diabetes. Now, these patients can present with what is called as overactive bladder, like I said, because of increased residual urine. So once there is an increase in the residual urine, there is again a signal sent to the brain. So because the bladder wants to void it, so the signals come back and there is contraction of the bladder with relaxation of the sphincter. So overactive bladder can be a symptom of underactivity as well. So that also needs to be diagnosed early on. Another question is, what are the reasons of urine leakage? I think I've already mentioned it in one of my slides where I've said it could be because of infection. It could be, like I said, it could be because of stress leak. It could be because of the urge leak, could be because of a neurogenic cause. It could be because of diabetes. It could be because of tumor. It could be because of stone, underactive bladder. And it could be because of prostate causing obstruction, as a result of which there could be residual urine, and that could be triggering the overactivity. So how can we make bladder strong? Yeah, one is retrain it, void more frequently, don't hold your urine for a very long time. Females have this tendency that they don't want to use public toilets, so they go for work in the morning, they come back home and pee. Now that is wrong, because you tend to keep the bladder relaxed for a very long time, and that is not a very good thing to do to the bladder. Another thing is, if you're obese or overweight, lose weight. That helps in strengthening the pelvic floor muscles. Do pelvic floor muscles, regularly exercise, and avoid the irritants to the bladder. So this is how you keep the bladder strong. So any other questions?
Ma'am, there are no other questions right now in the chat box. Can we wait another 1 to 2 minutes if any question comes?
Yes, sure.
Thank you. Thank you, ma'am. Thank you.
So there are no questions. We'll wind up.
Ma'am, still there are no questions in the chat box. So it's a pleasure to have you with us today on this topic. On the behalf of organizer, I would like to thank you for your informative and thank you so much, ma'am. So from here now, I'm ending this meeting.
Okay.
Good night.
Okay, good night.
Ma'am.